Okay. You are live.
Okay, welcome to the Insurance and Pharmaceuticals Subcommittee of the Health and Government Operations Committee. And on just 4 days before what we call crossover, lots of bills are happening. Schedule is in flux. I appreciate my committee and the advocates and stakeholders in these bills for your flexibility. I'm not sure why I'm echoing. Any idea why there's an echo? Okay, now it seems all right. We have 6 bills before us today, and we have a guest counsel here with us, and that is Erin Hopwood, and she's brought us House Bill 962, and that is
It's 926.
or 926 if you're not switching letters around. Healthcare malpractice claims, healthcare provider definition. And this is Delegate Williams' bill. Erin, you want to tell us about the bill and what it does?
Sure. And also on this bill, HGO is primary and judiciary is secondary. The bill expands the definition of healthcare provider under Title III, Subtitle 2A of the Courts and Judicial Proceedings article, which deals with healthcare malpractice claims, to include an employee, agent, or contractor of a hospital who is licensed, certified, registered, or otherwise authorized to render healthcare services in Maryland. There's a reprint that incorporates amendments that are being offered by the bill sponsor, who is Delegate Williams. And this clarifies that the healthcare provider definition would be expanded to include an employee, agent, or contractor of a hospital who is licensed, certified, registered, or authorized. It strikes the word otherwise. And it replaces the word render healthcare services to provide healthcare services. And it clarifies that the healthcare services are as defined in Section 19132 of the Health General article.
Okay, is Delegate Williams here by any chance? I don't see her.
Yes, she
Madam
is.
Chair,
Oh,
Madam
she is?
Chair, I'm sorry.
Oh, okay.
I'm
Okay.
double fisting right now because I'm in my own subcommittee at the moment. But I am here. I think the description that was provided was accurate. So yes.
Okay. Do you have anything to add? I know that there's still some opposition to the bill. So
Yeah, we've been working. Yeah, I know we've reached out to the Maryland Association of Justice on this to try, and we did make some amendments. Hopefully you have the amendments that is attempting to address some of their concerns.
Okay. Well, thank you very much, Delegate, and thank you for stepping out of your subcommittee to be with us for this bill for as long as you can.
Okay.
So I would like to go to Jake Whitaker to describe, in your words, who do you think would be covered under this bill?
Yeah, so under this bill, anyone who provides medical services who works at a hospital, basically anyone who comes every day to provide medical services. So we're talking respiratory care specialists, x-ray technicians, folks like that I think we all agree are medical providers. And this bill is kind of drafted in a way that specifically would exclude folks like security guards, custodians, or administrators. So we really just want to do what the medical malpractice statute is intended for, which is to file claims against medical providers. And we feel like we've really had some tight language here to really clarify that it's only those folks that are going to be under the statute.
And Jake, I have a question. So does this mean that those individuals in a hospital would be covered by the hospital's malpractice insurance?
Yes, so this bill has no bearing on the insurance status of any individual. It just basically says under what statute you'd file a claim. But many of these folks, to answer your question, many of these folks would be covered under the hospital's insurance. That's correct.
Okay. All right. Thank you.
Mm-hmm.
So do I have a motion on the amendments?
I'll move the amendments.
Okay. I've got a motion, a second.
Second.
Okay. Now we're going to go into discussion since we have something on the floor. And my friend George Tolley is here. George, hi.
Yes, hello, Madam Vice Chair. This is George Tolley. I got a notice today to attend your subcommittee. I got the language from Mr. Whitaker today. And we do have an issue with the amendment, which I can talk about. I can also kind of put the bill and the process in context. And I don't know whether Delegate Williams is still on the call or not. As we described during the hearing on the bill, this proposal was put forward sort of parallel to a different bill that has to do with the cap on non-economic damages. The hospitals would like to have the healthcare providers who work in the hospital all covered by the Healthcare Malpractice Claims Act. Currently, some providers in a hospital, particularly those who've never had a problem accessing insurance, like occupational therapists or acupuncturists or respiratory therapists, things like that, who may be employees of the hospital or might not be. They might be independent contractors. Those folks are not currently covered by the Healthcare Malpractice Claims Act, which has a different cap, a lower cap for them than applies to everybody else in a personal injury context. Getting to the amendment incorporates by reference section 19-132 of the Health General article, which does define healthcare service. However, healthcare service is defined to mean any health or medical care procedure or service rendered by a healthcare practitioner that, number one, provides testing, diagnosis, or treatment of human disease or dysfunction, or dispenses drugs, medical devices, medical appliances, or medical goods for the treatment of human disease or dysfunction. Historically, medical device providers, blood banks, Red Cross, for example, none of them, medical labs, have not been covered by the Healthcare Malpractice Claims Act. And so in theory, any medical device manufacturer that contracts with a hospital would suddenly be covered by the Healthcare Malpractice Claims Act. We view that as a not consistent with what we thought the bill was supposed to do. And we do have a problem with language that is as broad as that being added. I just put that out there. We have been talking amongst ourselves about language as well, but as far as the parallel bill in the Judiciary Committee, my understanding is that bill is not moving this year. The chairman did not put it on a voting list for yesterday, and I don't believe the chairman intends to put it on a voting list this week, which means crossover will come and go without that bill moving. If that bill doesn't move, there's really no reason at all to pass a bill to protect the hospitals from the negative effects of the other bill, because the other bill's not moving. And so I'll just leave it there. I know I've taken some time, and I apologize for being so wordy. But that's those are our concerns. We're not in favor of expanding the Healthcare Malpractice Claims Act just for the purposes of adding more people to it for no reason.
Okay. Thank you, George. Let's go with Delegate Shaleka.
I was just, I'm not sure I have the latest version of it. So is it, House Bill 926 and it's just slightly edited on the back?
Yes, I think that's the sum total of.
Yeah, you should.
The edit's just tiny. It's just striking out otherwise and
And render.
render.
Replaces
Okay.
render with provide, and it references 9132 of the Health Journal article.
Okay. In that case, yes, I was just wondering, an employee is very broad and a contractor is very broad. So I think that's kind of what George was saying as well.
Okay. Thank you. Delegate Johnson?
Thank you, Madam Chair. I want to make sure I understand it. Now, is this moving,
I cannot hear him
is this
as per
moving,
usual.
I don't know, is it mine or is it yours?
It's yours, Delegate Johnson.
Okay,
Be
so
close to the mic.
I'm right up on it.
Yeah,
So is does this put the non-healthcare providers under malpractice caps?
It does not. It is
Okay,
only
all right.
licensed, certified, registered healthcare services.
Okay, all right, thank you. Thank you, Madam
Okay.
Chair.
I'm going to go to Patrice Clark before I go back to Jake Whitaker.
Thank you, Madam Vice Chair. I am Patrice Meredith Clark. I am also here on behalf of the Maryland Association for Justice with George. And I just want to answer Delegate Johnson's question. I think, it depends on what you define as a healthcare provider. So as George pointed out, the definition that is incorporated into the new amendment references the Health General article, section 19-132H. And the definition of healthcare service in that reference includes healthcare service means dispensing drugs. So this is very different actually than the original language. It's even more broad than the original language, which we were already opposed to, because it includes anybody who dispenses drugs. I mean, that could be like a pharmaceutical manufacturer, for example. So that I just want to clarify that is still, I think, really broad and problematic.
Thank you. Aaron, I'm going to go to you for a second. So under the definition of providing healthcare services, would that include, it might include a pharmacist, but do you think it would include a manufacturer, a drug manufacturer?
I mean, I know Jake's on the call. I know that the idea of the bill was to get to people, employees, agents, contractors, and the licensing and certification and the registration goes to people, I believe is the intent. And then those people who provide the healthcare services and the reference to 19132, I believe, and again, speaking for the hospitals, was to provide clarity as to what is a healthcare service and to use an already existing defined term.
And employee is a person, right? Okay.
Yes.
Yeah. Jake Whitaker?
Thank you, Madam Chair. I'll just say the definition that we included was in response to the Maryland Association of Justice's concerns that healthcare services wasn't defined. I think we used a commonly used definition that's in Health General that relates to healthcare practitioners. And I think we have an additional kind of guardrail by saying someone who's licensed, otherwise authorized or certified to deliver these healthcare services. So it's not, an entity in another state or something. These are individuals working at hospitals. So I wanted to clarify that. We took it by our general counsel as well, just in good faith, to kind of work with the trial attorneys to kind of see what they were looking for. We came up with this language. We haven't heard any alternatives that would clarify, but we're happy to entertain that if they have anything.
George, you've been invited to give us an alternative that would achieve their goal.
To the extent that we want a definition that will be acceptable, keeping in mind that we don't want to see this bill move if our other bill doesn't move. But 19132H1 doesn't, so 19-132H is the definition of healthcare services in that section. There are a number of different definitions. Healthcare services is subparagraph H. And subparagraph H has two subparagraphs, the second of which is the one that's more problematic from our perspective in terms of the medical devices and so forth. If it were limited to H1, then it would strictly be practitioners who provide testing, diagnosis, and treatment of human disease or dysfunction. And I think that does a better job of limiting it to individuals. I agree that employees are typically people, living, breathing human beings.
Hope.
Contractors, on the other hand, could be businesses, LLCs, and other entities that are not living, breathing human beings. One other suggestion that I would make is to add that it's the employee, agent, or contractor authorized to provide healthcare services as defined in that statute while providing those services in the hospital. One of the concerns we raised earlier with the committee at the hearing and with Mr. Whitaker privately is that we need to know, as the lawyers who represent the folks who bring actions under this statute, we need to know where to file those. Are the people that we're looking at, are they covered or are they not? And we need to be able to tell before the case is filed. If we're talking about folks who are contractors providing healthcare services somewhere out in the field, and they're not otherwise covered, right? If they're doctors, we don't need this amendment. If they're nurses, we don't need this amendment. It's the people who are not doctors, not nurses, but are providing care services out in the field, out in the community. How are we going to know that they're under contract with a hospital so that we file the case in the right place and don't run into a problem where all of a sudden limitations have run and the defense says, haha, you filed it in the wrong place and now you lose. That we want to avoid that. And so if we can limit it to people who are providing care in a hospital, then that helps us to know who is covered and who isn't. And I believe that was the intention of the Hospital Association, to limit it to people who are providing care in hospitals.
Jake, I'm going to look at you. Is that correct?
So the intent is basically anyone who works for a hospital to be included under the statute. I would think even if it was an incident, I don't think this would happen, but if it was an incident outside of a hospital, George or his colleagues would still name the hospital as a party. So we think the intent is really to name everyone who works at a hospital, and that includes the employees, licensees, and contractors. So I don't understand how that would have any kind of bearing on whether or not this bill just affects medical providers, and I think it does.
So do you think, Jake, that if a person were named in a suit who works for a hospital but was, delivering service someplace outside of the hospital, that there would be recognition that they are working for the hospital?
Yeah, I would think the plaintiff's attorney would argue that they're acting under the apparent authority of the hospital and that the hospital is vicariously liable for their actions. I think the hospitals are perceived as having deeper pockets, meaning bigger insurance policies. So I would think that that's what they would do.
So I do have a question, George, another question. So why you read from 19, I should know this by now, 19-132, and it listed a number of services that are provided, including as part of treatment, the delivery of devices. So why do you think they should not be included in this bill?
I'm sorry.
Okay.
Yeah, and now I don't see myself. Oh, there I am. Anyway, so treatment includes devices. I'm sorry, Madam Vice Chair, I don't see that in that statute. I'm looking at 19-132H.
But I think that the general, the beginning, just not H, but the beginning of it defines medical services, right? Or healthcare services?
Healthcare, yes, H, before you get to the one, it does define healthcare services as a health or medical procedure or service rendered by a healthcare practitioner. And then it limits that to those procedures or services that either provide testing, diagnosis, or treatment of human disease or dysfunction, or in the alternative, dispenses drugs, medical devices, medical appliances. Historically, our court has interpreted our courts early on in the life of the statute interpreted the statute not to extend to blood banks, to medical device manufacturers, and things like that. So those are more product liability kinds of cases, not professional negligence cases. And product manufacturers certainly have never had a difficulty accessing insurance, which is the point of this statute, is to remedy historically the problems that doctors had and hospitals had accessing malpractice insurance back in the 80s and 90s. And so, if a hospital contracts with, say, Medtronic or a Meditech or some other medical device manufacturer to provide products to be implanted in surgical patients, and there is a defect in one of those products, including contractors who provide medical devices and appliances to hospitals, if they've contracted with a hospital, they're going to get covered by the Healthcare Malpractice Claims Act. And that presents an enormous number of problems. One of the requirements we have is we have to get an expert witness to sign a certificate of qualified expert. That's in a different part of the statute, because the statute is large and complex. That expert has to meet certain requirements that make sense when the defendant is a board-certified healthcare provider of some kind, either a physician or a certified registered nurse practitioner, because we know we can get somebody who's similar to that. There is nothing in the statute that provides any guidance whatsoever as to who would sign a certificate of qualified expert against a medical device manufacturer. And so medical device manufacturers, the statute was never set up to cover them. And if they're going to be bootstrapped in this way, that's a problem. And so what I suggested was taking only H1 and leave H2 out of it. And by limiting it to healthcare services as defined in H1 or as limited to H1, then we don't have to worry about whether it applies to device manufacturers or not. That's my point. I'm sorry if I didn't make that clear.
Okay, thank you. Jake, are you okay if H2 comes out of that section?
Well, just to use George's example of a medical device manufacturer, I don't think they would qualify using that definition, because the definition of healthcare services is qualified by saying it's delivered by a healthcare practitioner, and then it defines a healthcare practitioner as a human being, and like higher up in the statute. So I think the concern that George has isn't really there, and it's very clear from the statutory construction that we don't need to clarify that.
Does it hurt to take that out then, to take H2 out?
We prefer to
what
keep,
you need is in H1.
we prefer, just because we operate pharmacies within the hospitals as well, so drug dispensing would be important. And when we checked this with our general counsel, they thought this would be the best definition. From my understanding, this doesn't implicate medical device companies because it requires a healthcare practitioner to deliver those services. So if somebody dropped off a medical device from a manufacturer, and then if the healthcare provider caused an injury as a result of doing that, then the healthcare practitioner could be held liable, but not the manufacturer. It's really about the delivery of the healthcare service, not the, as George said, it's a products liability issue. It's if there's a fault with the manufacturing process or the design process of that medical device product.
Okay. Let's see. I think, there seems to be a little more work needed on this bill. I am so sorry. I was hoping that we could wrap this up. But Aaron, I think, I know that my committee is meeting tomorrow, and hopefully in the next 24 hours or so, we can figure out the language that would meet the intent of the hospitals, but also assure that manufacturers and outside folks would not be included under this. So without objection, I'll go to Delegate Schlega.
Thank you. Maybe because this is in, the part of the code we never deal with.
Right.
I'm gonna channel Sue Krebs here. What problem are we trying to solve? Is this trying to figure out who can be sued and who can't be sued?
Yeah, so there's generally two types of major kind of tort claims. There's the personal injury and wrongful death, and then there's medical malpractice. Under the medical, they kind of separate the two for a number of reasons. But under the medical malpractice statute, there's provisions for expert witnesses that can deal with and assess these kind of complex kind of cases. For example, whether or not a surgeon deviates from their scope of practice. There's also the health dispute resolution office, which kind of filters out some of the more frivolous cases as well. So there's a statutory framework put in place for these specific types of cases for those reasons. So we want to make sure that the folks that are being assessed under the proper statute. So if you commit a medical harm, you should be assessed under that statute that's designed to do that. So that's the problem we're trying to solve, because as the statute becomes more prescriptive and they start naming physicians or nurses, plaintiffs' attorneys are trying to argue that unless you're listed in that statute, you're not a medical provider as defined under the Medical Malpractice Act.
Okay, thank you.
Got that? Okay. Then I think we're at a point where we still need to wordsmith, and I am going to hold the bill and we'll talk about it tomorrow and hopefully come back with language that we can all live with. And thank you, Delegate Williams, for being here. We are going to move on to House Bill 383. This is Delegate Martinez. It's Maryland Medical Assistance Program and health insurance coverage for orthoses. So everybody can move Act this number 2. This is Act 2. Lisa, this one is yours, right?
Mm-hmm.
Okay.
Yes. So this bill alters the current mandated benefit for coverage of orthopedic braces to be coverage for orthosis and replacement of orthosis. There is an amendment that is distributed. The original bill came in, it would apply to carriers and Medicaid, and the amendment strikes out the provisions related to Medicaid.
Okay. Delegate Martinez, do you know if that removed the fiscal note?
Thank you, Madam Chair. So from my understanding, that does remove the fiscal note, because that was the only physical implications. And then I know there's also some potential technical amendments just on language that Cheryl wanted to proffer, if appropriate.
Certainly. But I saw Delegate Kipke. Was your hand up? Did I miss?
Oh my gosh, these buttons, the internet is slow. What a time to be alive. I was just going to ask the question. So obviously, so it sounds like what's being presented here is that we're excluding Medicaid and making the private sector pay for it. And so my follow-up question was going to be, and I'm sorry, I should already know this, but I'm tired. Has this already been reviewed, the cost of this, the process that we go through to see what kind of costs we're talking about? Have we already gone through that process?
We did, and we got a report from MHCC, but it was, and I'm gonna look, Lisa, you may know it better than I do. It seemed to me that the report was, there was a very high fiscal note for Medicaid, and I forget the range of increase for carriers. Matt or Kim, do you guys have that? Matt, what was it?
So, Madam Chair, it's hard to say because there's been a lot of conversations around this bill, and I know that the advocates had spoken with the folks at DLS too to get a revised fiscal note and talk to the health department as well. But I think the bill no longer applies to Medicaid because it's expensive, right? So we think that that's worth having a discussion about in the commercial space too. I mean, we have lots of federal employees that are losing their jobs that are now going to be looking to the exchange, and we are hypersensitive about any price increases on premium. Now, we only have 2023 numbers that the MHCC looked at, but if you use those 2023 numbers of covered lives in commercial, which is roughly about 850,000 people, The commercial cost estimate was 3.2 million. So if you take those people and divide by 12 months, it's about 31 cents per member per month, that's a lot for a mandate. Most mandates that carriers are comfortable with fall into the 5 to 7 cents per member per month category. This is much, much more than that. So it will have substantial impact on premium. That being said, like last year's bill, we are happy to continue the conversation. I know a couple of us on the call, including Cheryl, who I think is right behind me or in front of me. I might have jumped the line. I'm sorry, Cheryl. We are talking at 4 o'clock to see what kind of progress we can make here. But Medicaid was removed from the bill because it was too costly. And we are concerned that that same sort of cost is going to be passed along to consumers in the commercial market. And in these very sensitive times, it's a challenge for the commercial carriers.
So I'm going to take Cheryl and Kim, but based on what I just heard, that there is a continuing discussion at 4 o'clock today. And I know that this committee is going to meet again tomorrow. Then we'll hold the bill. But let me take Cheryl first so that the subcommittee knows what the conversation will include, and Kim, and then we'll move on from there.
Thank you, Madam Vice Chair. So a few things. So the first is the PMPM that I believe Matt's referencing is based off of the cost study report that MHCC and the Department of Health completed in between the sessions. There were significant issues with that report. So the data that MHCC used, they used the original 258 billing codes, which the Department of Health has now revised down to only 132 codes. So the data that they used to calculate that is no longer accurate. They also calculated it based on the idea that the reimbursement for codes, so the cost of the codes, would increase at a 3% margin, similar to Medicaid. But since Medicaid rates are tied directly to Medicare, and in prosthetics and orthotics, and in this case specifically orthotics, the reimbursement for orthotic codes is not accurate. I can't necessarily discuss details due to antitrust, but I know, for example, we have codes through Care First that haven't been updated, and the fees haven't increased in over 5 years. So with those two facts, it's hard to really say what the potential per member per month would be. The other thing I did want to mention, and I guess it's not necessarily relevant right now, but one of the amendments that we did want to discuss is just clarifying that the legislation is asking for provision of an additional orthosis for physical activity, in addition to the everyday device. What we've unfortunately found with the language from last year's legislation is that the carriers and Medicaid are kind of assuming it's an either or. So we did want to clarify that language. And then lastly, with regards to the fiscal note, Medicaid was removed due to some of the budget issues, but the fiscal note is actually about half of what it was last year. So I just wanted the committee to be aware of that. Thank you.
Okay, thank you, Cheryl. Kim?
I didn't take my hand down, but I will just say I'm part of the 4 o'clock conversation. And so we'll, rather than hash it out here, we're going to keep talking then. Thank you, Madam Chair.
Okay, thank you very much. So with that, we'll hold House Bill 383 and we'll go to House Bill 830, Health Insurance, Genetic Testing and Cancer Imaging, Required Coverage and Prohibited Cost Sharing. This is Delegate Jones. And I don't know if is Delegate Jones here? Did we get her here?
Madam Chair, my name is Josh Paper. I'm the delegate's chief of staff. I'm here for her. Okay. She is in committee right now.
Okay, great. Thank you for being here, Josh. Lisa, would you tell us what the bill does?
The bill requires carriers to provide coverage for genetic testing to identify whether an individual with a personal or family history of cancer has an inherited mutation associated with an increased risk of cancer. Carriers must also cover follow-up evidence-based cancer imaging if the genetic testing determines the individual to be at increased risk of developing cancer. A carrier may not impose a copayment, coinsurance, or deductible on coverage for genetic testing and any follow-up evidence-based cancer imaging, with the exception of a deductible for a qualified high deductible health plan.
Josh, did you want to say any more about the bill?
Nope, I think that's a great description.
Okay. And Lisa, am I correct that there are no amendments on this bill?
There are no amendments.
Okay, I see Matt Celentano's hand up.
Surprise, surprise, Madam Chair.
Yes.
So our opposition remains to this bill as it did in the hearing, and mostly because of the discussion that happened at the Healthcare Commission when they reviewed this bill last interim and discussed it at the November MHCC meeting, when a few of the providers that are MHCC commissioners suggested that the commission not endorse this concept or this proposal, mostly because the tests aren't really that effective or accurate. At the best, they're between 40 and 50%. And because of the medical history that exists for a lot of the folks that would be getting these tests, it sort of serves as duplicative testing. Carriers are going to want you to get further tests anyway, and this test, we think, only adds cost to the system. If you are going to be eligible and you have family history, there's going to be a variety of tests that the carriers are going to want you to have. This test does nothing more to us than add cost to the system and doesn't get the impact that we think that the bill's intentions to point to. So we continue to oppose this bill.
Thank you, Matt. Kim Robinson.
Thank you, Madam Chair. I just want to add just a little additional color to what Mr. Celentano just shared about the bill. Yeah, I went back and listened to that conversation he referred to for the Maryland Healthcare Commission. And what stood out to me in the discussion that was had during that particular work session was a couple of things. So one, although the MHCC studied it, they said very clearly in their review of their findings that the charge for what they were studying was only on removing the cost sharing aimed at what we already were covering at the time. And so what the bill is doing is not just removing the cost sharing on what was already being covered from a genetic testing standpoint, it actually seeks to expand it. And that was actually not studied by the MHCC for cost. And so I do want to flag that for the committee, that your bill does not align to the inquiry that took place to determine what the cost implication was. I've heard, there's a variety of numbers they put in there. It doesn't seem quite so big, but it also is not reflective of the cost of this particular bill. Two, I think one of the other really salient points that one of the providers on the council, or on the commission rather, flagged in that discussion was around what is the real total cost of all of this? What comes from testing where the indication is not as strong. So for instance, BRCA1 and 2, that testing has a very strong correlation in the scheme of genetic testing, right? 45 to 55%, depending on which of those two markers one may have, or if they have both. And that is not the threshold for other genetic tests. Also coupled with the fact that even if one has the genetic marker, you're only about 10% more likely than the average population to actually develop the cancer despite the marker. They felt like there was a need to be sure that the state was not getting ahead of the science. I think the bill attempts to give a nod in that direction, but I don't know that I think the language really curtails it to being able to follow, truly what the evidence-based medicine is, not just people seeking them, because I think we all have anxiety about it. And I say that as a person who has done the genetic testing, done the genetic counseling in a former life. MindSure well over a decade ago paid for my BRCA1 and 2, paid for the genetic counseling that came along with that. And it was based on the strong science around those particular genes. And so lastly, in addition to the cost of the testing, all of the ancillary services that come with the efficacy. And the third thing that the commission really flagged was around the idea of removing cost sharing. And I will just say, taking a page from one of my favorite lobbyists on another part of the healthcare industry, to flag that you've got a lot of bills that are removing cost sharing from insurance, and that there is a financial consequence to that. We talk about, getting a fiscal note off because we took Medicaid out does not remove the actual cost to the people who are paying the premiums out of their pocket for insurance. And so your constituents still have that cost implication. The lack of cost sharing does raise the cost of insurance. And at some point it is going to become an issue, even in our individual products, as we have to meet actuarial value on metal levels. And so, I think there's a lot to really be considered about this bill. I think there's a lot of good that's intended by the proponents, but I think that there needs to be some tightening of that language and some more work done to make it make the most sense. Thank you.
Thank you. Okay. I suspect we're going to hear the other side now. Patrick Hogan.
Thank you, Madam Chair. I will be very brief. Patrick Hogan, Cornerstone Government Affairs, representing our client Susan G. Komen, who is also in the meeting. Very simply, want to say that MHCC study came back. One of the key things that we saw was they estimated it would be about 6 cents per member per month or less for this kind of coverage. So we think a pretty minimal cost for really significant help for these high risk individuals who are facing this. So we would again appreciate the subcommittee support, and as I said, Angelica Katz from Susan G. Komen and actually some other advocates, patient advocates, are on as well who can share additional information.
Thank you, Lisa Schlager.
Thank you, Madam Chair. Lisa Schlager with the organization Force for Facing Our Risk of Cancer Empowered. As much as I appreciate the perspective of our insurance industry friends, I'm afraid they're misleading the committee. The genetic tests are exceptionally accurate at identifying what they're meant to identify, which is a specific genetic mutation. So BRCA genetic testing, for instance, is over 99% accurate. Testing for other mutations is approaching that accuracy level. And when an individual tests positive, there are very definitive things that they can do that are guideline recommended under the National Comprehensive Cancer Network that an individual without a mutation may not qualify for. I think the premise of this bill is for these individuals, it can be very costly to try to remain healthy. And if we're not helping them access these services, such as breast MRIs or earlier, more frequent colonoscopies, ultimately it costs the health system money in the long run because they can't afford to get the screening and they end up getting diagnosed potentially at a later stage than they would if they were able to access those screening services. And the reality is, a BRCA mutation can face far more than 10% higher risk than the average population. The average population woman has a 13% risk of breast cancer. A woman with a BRCA mutation has a 60% or more lifetime risk of breast cancer. So that is far more than an additional 10%. I'm happy to answer additional questions, but I want to give others an opportunity to speak. So again, thank you for the opportunity to share with you today.
And thank you. Thank you for coming. I'm going to go to Delegate Kaiser.
Thank you, Madam Chair. And real quickly, and thank you, Ms. Schlager, for responding to the prior comment, because I don't think it was just the accuracy. I only heard them make the claim that it was 10% or 10 percentage points more if you had the marker. So I guess from Kimberly, who said one thing, and from Ms. Schlager, who said the other, I guess the whole committee would like to see that distinction, because I think it matters, or what the data is, because I feel like that would make a difference. Thank you, Madam Chair.
Thank you, Delegate. So I'm going to go to Angelica Katz.
Great. Thank you, Madam Chair. And I appreciate the dialogue and everything that the subcommittee has already done on this bill. So I just want to reiterate a few points. So there seems to be a fundamental misunderstanding regarding the purpose of genetic testing in cancer prevention. So genetic testing is not intended to diagnose cancer, but rather to identify individuals at an elevated risk, as Lisa mentioned, and to prevent any cancers from developing. So there's a critical distinction because it shapes how we, think about prevention and early detection. So this is a cost savings bill. I just wanted to reiterate that point as well. And the claims that, genetic tests are only useful if the patient already has cancer really is misleading. So, genetic tests should not be measured by whether or not the patient currently has cancer, and it's really designed to predict risk and to help create a management tool around that. So yeah, I'm just, I'm happy to answer any questions, and just wanted to reiterate that point.
Okay, thank you. All right, we'll go back to Matt.
Thank you, Madam Chair. I know it's crossover week, and I know people's anxiety is up high, but I really don't appreciate being said that we're trying to mislead the committee. We're not. The commission had a report done by Lewis and Ellis, which is an actuarial consulting firm. The report is 16 pages long. It's on the MHCC website. The statistics that we refer to are on page 4 and 6 of that report. This is an independent actuarial analysis firm, so I just don't really appreciate being saying we're misclassifying. To the PM, there was a range from that report. At the low end, it is 2% or 2 cents per member per month. The mid range is 17 cents per member per month, and the high range is 53 cents per member per month. In the prior bill, you heard us talk about how that anytime outside of the 5 cents, we get uncomfortable because of the added cost to premium. It is our understanding from some of the actuaries who work for the companies that this would be more in the high end. Within the study that the committee should have, is on the website, the MHCC, that the most likely outcome would be mid-range. That's still 17 cents per member per month. That's almost 3 times more, or it's more than 3 times what the carrier is usually comfortable with the additive cost that goes into premium. So this is a decision, obviously, for the committee to make as they move forward. But the study showed that private health insurance already covered genetic counseling and testing with low or no cost sharing or out-of-pocket costs for people with family cancer history. So we believe this bill is repetitive and creates more cost to the system, not less. This was echoed by multiple physicians on the MHCC that this was not an approach that was medically necessary. It would only add cost to the system. So for those reasons, we're uncomfortable with the bill moving forward. Thank you.
Thank you. Kim Robinson.
Madam Chair, I will defer to the comments of Mr. Celentano to clarify what was said before and what is reflected in the MHC study, and I'll leave it at that.
Thank you. Deborah Coleman.
Good afternoon. My name is Deborah Coleman, as you just said. I had the pleasure of providing testimony to the committee recently. And this is my first time participating in this process, so just bear with me here. Hopefully I'm not out of order. But one of the things that I would say, I also appreciate the dialogue. But one of the things that I would ask is, at a basic level, if you were faced with a cancer diagnosis, in my case, it was breast cancer, and another gastrointestinal cancer, would you not want to have access to this testing? That is the bottom line. Whether it is predictive or not, you want to have all of the information available to you so that you have peace of mind knowing how to move forward. So that is why I strongly urge the committee to pass this legislation. And I'm happy to answer any questions if you have any for me. Thank you.
Thank you. Thank you for being here. Josh from Delegate Jones' office.
Just quickly, because Delegate Kaiser mentioned it, there's a lot of expertise on this call, but I can do a little research, and based on the research that I have from the National Cancer Institute, the data suggests that 60% of women who inherit BRCA1 or 2 will develop breast cancer during their lifetime, over 13% for general population. I'm happy to provide that site for you as well, Delegate Kaiser.
And I understand that the test for BRCA1 and 2 is pretty reliable. It's the other tests that I think we're talking about. The reliability is a little bit lower. Lisa Schlager, and then I am gonna.
Thank you again. So I happen to carry a BRCA1 genetic mutation, and I have benefited from that knowledge tremendously. I have not had cancer, but I was able to use that information to screen much more intensively and to undergo risk-reducing surgeries, thereby reducing my risk to the point that I'm healthier than the average woman, because I've been able to use that information to be proactive. And while some of the other mutations are considered somewhat newer and we are still gathering information, the reality is that many of them are quite similar to the BRCA mutations with slightly varying cancer risks. And for people who are identified with one of those mutations, the information that we have is very clear on what they can do to manage or reduce that risk. So You are correct that only 10% of all cancers are going to be due to someone who has a hereditary cancer mutation. But for those people who have mutations, this information is life-changing and life-saving. Many people may have risk for other reasons, but these mutations fight cancer, basically these genes fight cancer. And so when there's a mutation, the cancer, unfortunately, is more likely to occur. Happy to answer more. And we have provided some statistics similar to what Delegate Jones shared, and we're happy to share additional statistics, but the information is very clear.
And I appreciate that. Okay, I am going to hold this bill. And what I am going to ask is that the carriers look at the language of the bill to see if there's any place that we can constrain the cost. Because right now it's pretty broad and it covers a lot of things. So I'm wondering if we can take a stab at, is there anywhere in here where we can figure out a way to make it less expensive at this moment and see if we can go forward from there. I'm going to ask the committee, are you comfortable with that? Anybody object to that? Okay, thank you all. Thank you for the conversation. I truly appreciate it. Okay, we're going to go back to genetic testing now. And this is House Bill 1007, genetic testing, prohibition on disability, life and long-term care insurance, genetic testing protection act. And this was Delegate Wells. Any notion of whether or not Delegate Wells is able to attend? Anyone? Brigida, did you get any information from her?
No, I haven't received anything from her, but her subcommittee is still meeting.
Okay. Okay, let's hold it for a little while to see if maybe she'll have time to come on before we go on to that. Delegate Kaiser, you had a question? No? Okay. Then I'm going to skip 1087 and 1310 for right now. We'll come back to it. I want to go down to House Bill 1315. This is health insurance coverage for child, youth, wellness services, immunizations. And Lisa, tell us about the bill.
This bill requires specified insurance policies and nonprofit health service plans to include in their minimum package of child wellness services required under current law all visits for and costs of childhood and adolescent immunizations recommended by the American Academy of Pediatrics. There are amendments that have been distributed that do several things. First of all, the amendments are specifying that the pharmacist's authority to administer vaccinations, the current authority, is based on recommendations of the CDC's Advisory Committee on Immunization Practice as of December 31st, 2024, or at a later date that enhances access to vaccinations. Similarly, the amendments of the bill that apply to childhood vaccinations we are removing the references to the American Academy of Pediatrics, and we are saying that the amendments, or excuse me, that the coverage requirements are connected to the CDC ACIP recommendations as of December 31st, 2024. And the amendments are also changing the effective date to June 1st, 2025. And if Delegate Gazzoni is on here, I think that I got everything, but I could be wrong.
Delegate Gazzoni?
Yes, and thanks, Lisa, for all your work on the juggling that we've been trying to do. I do think that folks from Department of Health are on, and they may have some additional comments that they want to share. I think specific to the changes to including the American Academy of Pediatrics. So I will defer to them unless you have other specific questions for me.
No, I don't. And I am not sure I can't see everyone on my screen, so I'm not sure who's here from MDH.
I am here. I'm here, Chair Collison, if it's okay.
There we
Megan
go.
Lynch, sorry,
Hi,
Deputy
Megan.
Director for Government Affairs. Thank
Yes.
you. And thank you, Delegate Gazzoni. We're certainly good with the pharmacist amendment, and I think generally speaking, good with Matt's additions. We would just caution and really push back against the deletion of AAP from the bill. That's kind of where the department is right now.
I think AAP is in the bill.
It's at the bill in one place, but it was struck as it relates to, I believe, the coverage requirement, which I think was in the league's amendments.
Not that we could see.
Okay.
Is our understanding.
Right now, as I look at this and I'm looking at the reprint on page, the second page 2 of 3, at least I think. Line 16, it is taken out at that point because we shift the CDC language to as of December 31st, and then drop in on page 3 of 3 the language that we used in 974. Delegate Shetty spill on preventive services.
Okay. So Megan, is that sufficient or, but is that sufficient? Let me just ask it that way. Or you need it to be restored based on the December 31st, 2024 date.
Our understanding is that we would prefer for it to be restored based on the December 2024 date. Is kind of our initial take on that, but we do know that I think it adds some in Matt's amendments as well. It adds some regulatory, I think, authority for MIA. So I think it gives us a bit of flexibility there too, in case we need it. But that was just our flag.
Okay. I'm gonna go to Delegate Szeliga and then to Matt. So Delegate Szeliga.
Thank you, Madam Chair. So if we don't pass this bill, kids are still going to get vaccines. Is that correct?
Correct.
Okay, so
as
Sue Krebs would say, what problem are we trying to solve?
And I think what we're trying to solve, not I think, I know what we're trying to solve is we're trying to make sure that protections that we have currently in law under current federal guidelines remain in law in perpetuity.
What if there's a new innovative vaccine? Are you going to come back and need a new bill?
I'm going to look to experts to answer that question. Aaliyah, do you know that answer? Would this not cover all future immunizations as well?
The amendment is drafted allows, I think Aaliyah froze there for a second. But the amendment is drafted allows for that date or for other vaccines at a later date, as long as it's increasing access to vaccines. So it would allow.
Okay. So I'm still then confused why we need the bill. Because if it allows current vaccines and then future vaccines, you know, I'm still quite confused.
It's, as I said, it is to make sure
I think
that
if I could step in.
Okay. All right. Aaliyah, go ahead. Oh, you're on mute.
I think Delegate Gazzoni was trying to weigh in.
Oh,
okay. Yeah, and I'm sorry. Then I got a little instability here, but I seem to be back. From my point of view, the reason that we're trying to do this the way we are is to ensure that if the current list that comes through the CDC through the and I'm not going to be able to find the name of the organization that provides it. But that's an organization who's already had one meeting that was canceled and has not yet been rescheduled. I think we're all aware that the current Secretary of Health and Human Services is not necessarily the biggest pro-vaccination person known to humankind, and we're in the midst of a pretty sizable outbreak of measles. And so this is to help ensure that currently immunizations that are on the current CDC list do not get dropped off.
So I'm afraid of RFK Jr., Bill.
A little
Afraid
bit,
of what
yeah.
RFK Jr. might do, Bill.
Okay.
Yes.
All right. Thanks.
Yeah.
At least you're honest.
Sure.
Delegate Kaiser.
Thank you, Madam Chair. And I guess I had a question looking at the language and reacting also to Delegate Shalega's question. It's not about fearing person A or fearing person B. It's about knowing what they have said on the surface and wanting state law to be a certain way. And the federal government may not go down a certain pathway we're expecting. And if they don't, we're fine. But if they do, then this bill would be necessary. So, but as I saw, and I just wanted to make sure I had it up on my screen, sorry, as I look for it again, that we're using those recommended by the American Academy of Pediatrics. So we don't have to update from one year to the next. So it seems like it even has nothing to do with RFK Jr. or anyone who's the Secretary of Health and Human Services. It's really tying ourselves to a respected source, the American Academy of Pediatrics, whether there's changes in other ways in federal law or executive orders over the next decade or two. So I think it in some ways has nothing to do with RFK Jr. So thank you.
Thank you, Delegate. Aaliyah Horton.
If I may, thank you. So we do have concerns. Pharmacist authority to administer vaccinations is based on the ACIP guidelines and recommendations. That's for adult vaccinations as well as for children. And so if there is a change and that committee ceases to exist, the recommendations are completely removed, then that immediately ceases for pharmacists to be able to do that service. And as you know, the vast majority of vaccinations in the state are done in pharmacies. And so we want to ensure that we maintain that. There are different, I'll leave it at that. Thank you.
Thank you. Joy, so let me ask again from Megan from the Health Department. In the reprint, we have the American Academy of Pediatrics on unnumbered page 2. So approved or authorized by U.S. Food and Drug or recommended by the American Academy of Pediatrics. Do we need it again?
I think we do, Madam Chair, because I think that particular part of the bill is specific to the pharmacy stuff.
Yes.
And so we need to put it into the insurance.
Okay, so we
Yes,
do need
exactly.
Am I right? Am I right,
exactly,
Lisa?
right.
Okay, so we do need to restore it on page 2, line 16 and 17.
That would be our recommendation.
And I do want to remind everybody that currently, and it would be going forward unless there's some sort of significant change, the ACIP list, which is what the CDC's group comes up with, and the American Academy of Pediatricians lists and schedules are the exact same.
Thank you.
Currently.
So I'm going to go to Matt, and then we're going to look at the amendments.
Thank you, Madam Chair. I do not want to throw sand in the gears of this important conversation at all, and I'm not going to. The reason that the AAP was taken out in the, or we requested to be taken out in the insurance section is we wanted to align with the preventive services bill that you all passed already. And I see this as another ACA sort of codification effort in the grand scheme. And having two standards would have a direct conflict to that preventive services bill. And we want to make sure that no carrier has to have competing standards across the bills to sort of figure out how to implement. So it was cleaner to align with 974, I believe was the bill, and tie it to a date as of December 31st, 2024.
Lisa, I'm going to look to you. Because I think you were working on 974 as well.
The language that was recommended by the league does mirror what was in the preventive services bill.
Okay.
So I guess my question is there a conflict because I think the preventative services bill has a as of 12/31/24 date in it also.
That's correct.
I should know this by absolute heart. So if we include on the insurance side of it, the 12/31/24 date, and then also and the AAP, plus the that last part that we added in that's also in HB 974. Are we okay? Can we do it that way, or does that? I'm talking kind of you, Matt, whether that continues to cause confusion. Because again, at least right now, AAP and ACIP are the same. And hopefully will continue to stay the same.
Yeah, I'm not sure how to answer that, Delegate Gazone. I hadn't thought about it that way. Delegate, my colleague, Ms. Robinson, looks like she's aching to get into the conversation, so she might be able to provide some insight.
No, I think, and thank you. And that's okay with you, Madam Chair.
Yes.
Okay, thank you. And I think that's a great question, Delegate Gazone. So I think here's the challenge from the carrier perspective, right? I think we're all hypothesizing on what may change down the road. Let's pretend for a second, though, nothing actually changes. Right now, if the law at the federal level stays intact, we are bound to cover the things that are on the USPTF list of preventative services. And the AICP standard is the one that they're currently using, not the AAP. They may be aligned, but it's not what it points you to. And there are benefits to being covered under that list. It affects your cost sharing. It makes them preventative. It makes them automatically first dollar services. If we were to add a second standard that we're all now trying to implement, and today they're aligned, but let's pretend they're not, now that one-off immunization or something else, if the rest of the law has stayed intact, is no longer covered as an actual preventative service under the federal law. And so I think it's 974, Delegate Shetty's bill that really is tracking what the current federal law today uses the AICP standard. The amendment that Mr. Celentano submitted aligns to that bill. And I think really this is not a hostility at all to the American Academy of Pediatrics. It is really about staying aligned with the purpose of the bill, with the federal law that creates other requirements for carriers. And when we start to deviate for that, it makes the implementation for insurers challenging. It affects cost sharing and other things for members. And we're trying to keep it status quo and clean.
So I don't think we're quite ready yet. So Delegate Gazoni, I'm going to ask you to coordinate with MDH and either Matt or Kim from the carriers to work out that piece there. And tomorrow we will whip through it like that. Okay? So we will, and please don't be offended by the fact that we're holding these bills. It's because they're very important bills and we're having a really good discussion on all of them. So I appreciate this. We are only going to do one more bill because I know there's another subcommittee that is waiting for us, and I know that we're going to meet tomorrow. So I'd like to go to House Bill 1007, Genetic Testing, Prohibition on Disability, Life and Long-Term Care Insurance, Genetic Testing Protection Act. And I understand that Patrick Hogan is going to be representing Delegate Wells. Lisa, tell us what the bill does.
I'm sorry, I lost. Which bill did you just say?
1007.
Where did the folder go? Let's see. Okay, so there were amendments distributed, and with those amendments, the bill will prohibit an insurance carrier that offers, issues, or delivers a life insurance, long-term insurance, or disability insurance policy or contract in the state from unfairly discriminating against an individual by conditioning insurance rates, the provision or renewal of insurance coverage, or other conditions of insurance based on medical information, including the results of a genetic test for which there is not a relationship between the medical information and the cost of the insurance risk that the insurer would assume by insuring the proposed insured. Ooh, yeah. In demonstrating this relationship, the insurer may rely on actuarially sound principles or actual or reasonably anticipated experience.
Okay, thank you. I'm going to tell you where these amendments came from. I looked into what other states were doing, and I looked at several of other states, and where there was consensus or agreement. I don't know if it's consensus, but agreement on from the advocates as well as the legislators. And I felt like the bill from Vermont was the closest compromise that I could find in this arena. I will tell you that the carriers have said to me they continue to have very serious concerns even about this bill, but that this at least takes us a little bit farther down the line, and for what the advocates were looking for. So actually, before I go to Patrick, I'm going to go to Vince Ryan to sort of explain this bill, and because I think you were involved in its passage in Vermont, and what how we got to this place in this language.
Thank you, Madam Chair. Members of the subcommittee, Vince Ryan on behalf of the American Council of Life Insurers, appreciate the opportunity to be with you today. Yes, ACLI was involved in the passage of the Vermont legislation, which was at this point several years ago. It's been on the books for quite some time now. This is now the third year in a row that this body has considered the same legislation in the original version of House Bill 1007. Throughout this process, we've heard proponents as well as members of the committee ask industry to come to the table with workable alternatives. And Madam Chair, yes, while we would prefer that a bill not move forward, as we still have concerns about the regulation of the use of genetic test results in life insurance, we believe that the amended version of House Bill 1007, modeled after the statute in Vermont, again, being in place for several years now, is an amicable compromise that has been offered. We believe balances consumer protections with the need for life insurers, our members, to be able to accurately underwrite risk. And with me today is Dr. Rengachari, a medical director from one of our member companies, as well as Jan Graber, a senior actuary with the American Council of Life Insurers, who previously served as the chief actuary at the Texas Department of Insurance. And we'd be happy to answer any questions that this committee may have. Thank you.
Okay, thank you. Thank you for being here. But I'm going to go now to Patrick Hogan, as we're wondering where folks are on this now.
Thank you very much, Madam Chair. Patrick Hogan, Cornerstone Government Affairs, representing the ALS Association, and Lindsay Jack from the ALS Association, as well as some other members, some health advocacy members from the coalition supporting this bill are in the meeting. So certainly understand, well, first let me say, Madam Chair, I really do appreciate you and the subcommittee taking a close look at this bill and trying to get to a place where you can hopefully move it. However, I can understand why the insurers like this version of the bill, because essentially it just codifies what they're doing now. So we do have some concerns. We want to keep talking with you and the subcommittee to get to a place where you can move this bill. But the amendments that are proposed here, basically allowing them the flexibility to use genetic information if they can justify, basically they can discriminate if they can justify it actuarially. Again, we just think codifies what they're doing now and just does not provide the protections for folks that we're really just trying to get people to be proactive with their health with these genetic tests. And unfortunately, we think this would still allow insurers to discriminate. So I will stop there, Madam Chair. Again, thank you. And I do want to point out, as I said, our client, ALS Association, Lindsay Jack, is here representing them.
Thank you. I'm going to take Lindsay and then Ms. Graber. And then we can continue the discussion, but I will be very transparent and fair and say I have grave concerns over the original bill because of the way life insurance works. It's not the same as health insurance, and everybody gets paid no matter how much they've paid in. Everybody gets paid the amount that they bought for the program that they bought. So we have to keep that in mind. And we've had the experience in long-term care insurance where companies have shut down, where premiums have gone up 1,000%, and I'm not exaggerating, in 20 years because of actuarial challenges. So I've actually been a part of legislation that's dealing with that. So we have felt it. So I'm going to go to Lindsay now.
Thank you, Madam Chair. And again, we really appreciate the opportunity to think through this and have this conversation. But like Patrick mentioned, we do have some concerns with this amendment. So now, instead of a ban to use genetic testing for issuance and pricing determinations, this bill now allows insurers to use flexibility to use genetic information themselves if they can justify it actuarially. And that is completely up to them on how they want to justify how they could potentially discriminate against an individual who is receiving genetic testing. So we certainly have concerns with that. We want to work with the subcommittee and we want to work with insurers on how we can, potentially move this forward. From the patient perspective, this is prohibiting folks from receiving genetic testing right now. If there was no issue, we would see a lot more people receiving genetic testing right now. And, there is some language that I would like to share with committee staff, and it pertains with some written consent that folks can potentially do when they're before folks using an individual genetic information for the underwriting process. So we do have some written consent language that we'd like to propose to the committee and to the insurers to review. I'd also, because we are looking at this from the patient perspective, and we like Patrick said, can understand why the insurers like this language, to kick it back to the insurers, and ask, what protection does this provide for patients? What does this amendment do to actually make sure that folks, aren't, discriminated against when, receiving genetic testing? Thank you.
Okay, I'm going to go to Ms. Graber. And we only have about 5 more minutes, so I can take the last 3 hands and then we'll wrap up.
Okay, I'll go quick. Thank you so much for letting me talk to you about this, giving me the opportunity. And this amendment just really reinforces a fundamental principle of all insurance and that's that premiums must be actuarially justified. That does not mean that the insurance company can just decide how they want to do things according to how they want to do things. As an actuary, I must comply when pricing any product. I must comply with actuarial standards of practice. And those are my professional standards in order to remain credentialed. So, Premiums must be actuarially justified. They must accurately reflect the risk that the insurer is taking on. It specifically prevents insurers from unfairly using medical information, such as genetic test results, unless there is a clear evidence-based link between that information and the actual cost of providing the coverage. And insurers can only use this information if it genuinely impacts the risk and is supported by established actuarial principles. And if we incorrectly assess risk and premiums are not reflective of the underlying risk, then it disrupts the whole financial balance that is needed for a viable, sustainable insurance system, and creates unintended consequences that lead to higher premiums for everyone, or companies exiting the market altogether, which harms both consumers and the broader insurance market.
Thank you. Mr. Rengacheri?
Thank you, Madam Chair, and I'll try to keep it brief as well. First of all, I'll echo what both sides have mentioned. I appreciate the efforts that have gone to find some compromise language, hopefully amenable to a wide group of people. I was actually involved in Vermont, and that language came as a result of several rounds of hard-fought negotiations, again, on both sides. And I've been here now for 3 years in Maryland, and hopeful to come to a reasonable conclusion here. I thought maybe I'd address 2 points that have been made. One was the question around what does this ultimately provide then in terms of additional protection for consumers? And where I'd agree with Mr. Hogan is that it really provides that additional codification language. There have been misconceptions, I believe, around insurers just finding that piece of genetic information and automatically declining the application there. And this would prohibit insurers from doing so. They would need to look at the entirety of the case. And to borrow a phrase from previous debate today, they would need to practice evidence-based medicine. They would not be allowed to act simply out of fear or the lack of knowledge about a genetic test. And it would necessitate that they would have the appropriate resources, be they medical or medical combination with underwriting, in order to determine what that risk is, while at the same time providing appropriate protections for the other existing policyholders in the state of Maryland. Because we have the additional responsibility, as you nicely articulated, that we have to issue policies that are sustainable for 20, 30, 40, 70 years into the future, in contradistinction to the health insurance a way of doing things. Finally, while I appreciate the language and offer around written consent, I'll just note that for any piece of medical information that we use in the process, we already have an existing robust medical consent procedure. Thank you.
Thank you. Okay, Lisa Peabody, you're going to be our final
Hi.
word today.
Okay, thank you. Thank you so much for letting me speak today. I'm also with FORCE, and we represent those individuals with a genetic mutation, putting them at high risk for cancer. And I'm really not trying to be controversial. I am confused about this one piece, and that is when we talked about the other genetic counseling, genetic testing bill, there was evidence that those genetic tests are inaccurate. But here, the insurance lobbyists are saying that they must have that information. And is it accurate or is it not? It almost feels like a double standard. And I just want to better understand why it's accurate in one place and not in the other. Somebody can answer that.
You ask a good question. Okay, Vince, we're going to have to come back on this because we've got to wrap up. There is another subcommittee that's waiting for us. We know that we are going to be meeting again, so please watch your emails, and we will delay on the other 2 bills that we had today. Thank you all very much, and we are adjourned for today. Thank you for your discussion.